Hi, everyone. Welcome to the 2026 APAMSA OBGYN Bootcamp. We're really excited to have everyone here today. My name is Helen, and I'm one of the alumni directors and very excited to be part of the 2026 Bootcamp series overall. If you aren't familiar, the Bootcamp series is a series of sessions that covers high-yield topics for rising sub-interns and also generally includes a lot of important clinical information and pearls for clinical year students. This year, we're really excited to be offering 11 boot camps, and some of them have already happened. We still have several that are going to happen in the future. So if you're interested in any of the boot camps listed here, you can actually register for these on our website, apamsa.org. In our website, if you go to the strategy branch tab, there is a web page actually for the 2026 bootcamp series, and you can register for any of the upcoming sessions. Today, we're really excited to be having a bootcamp series that's focused on OBGYN. And we're really excited to have APAMSA alumni faculty and residents today to be leading and hosting this session for us all. With that, I'm going to pass it off to Ray to give a quick introduction to our speakers.
Hi, good afternoon, everyone. My name is Ray Hu. 8 years ago, I started this bootcamp series because I noticed there is a wealth of resources dedicated to acing your med school clerkships and step exams, but it was much more difficult to find teaching material dedicated to this window where you transition into sub-internship or internship. So I'm very thankful that this year we can offer a new specialty, and we have the pleasure of having Doctors Ganti, Liu, and Gambala, and very excited about what we will learn today. I'll pass it off to our student leader, Alan, to introduce our speakers.
Hey all, my name's Alan. I'm this year's APAMSA OBGYN specialty lead, and again, really excited to be offering the boot camp. This is our first year doing the OB-GYN boot camp, which is really awesome. So whether you're a rising intern, a rising sub-I, or a junior medical student interested in OBGYN, we have some great physicians here to give a really insightful talk on sub-I and intern boot camp knowledge. So I'll let Doctors Ganti, Doctors Liu, and Dr. Gambala introduce themselves, and then we'll get started.
Hi, I'm Dr. Ganti. I served on the APAMSA National Board for years while I was in medical school, completed residency last year, so I'm a new attending generalist at Indiana Regional. Thank you.
Hi everyone, I'm Dr. Connie Liu. I was a part of APAMSA in medical school at Brown, and then I did my OB-GYN residency at Northwestern, now a complex family planning fellow at University of Illinois in Chicago.
Hi everyone, I'm Cecilia Gambala. I did my OB/GYN residency at University of Illinois Chicago, which was great to hear that Connie's there, as well as my maternal fetal medicine fellowship. I went to school actually at Tulane and then, of course, returned back to the good old city of New Orleans, but very happy to be here. Thank you.
Just before I let our speakers take it away, I just wanted to give a quick slide on audience participation today. We would love for you all to be an active part of this session. To do so, there's a couple options here. If you have any questions that you'd like to drop in the chat box will also be monitored by any of our speakers. And so please feel free to do that. Additionally, if you would like to ask a question, if you could use the virtual raise your hand feature, unmute, and then go ahead and introduce yourself as well. So your name, your school, and your year of training. We would love for everyone to be an active part of this session. With that, I will go ahead and let our speakers take it away. Thank you, everyone.
Okay, so we are so excited to be here today. And like Helen said, we really want this to be an interactive session, right? Because we've all been through so many didactics and lectures, especially as most of you are in your fourth year and getting ready for residency. And one of the main changes between medical school and residency is you actually get to start doing. Can everyone hear me okay? Okay, perfect. And so, yeah, so once you enter residency, you're going to be the person doing all of these things, answering these questions. And so we really want to create a sort of environment in a safe and healthy way. And so we will be going through a series of cases that will cover high yield topics in gynecology, in office, and in obstetrics. and we'll move through high yield topics in those sections. So my section is going to be gynecology. Dr. Ganti is going to take it away with office, and then Dr. Gambala with OB. And then between each section, we'll give everyone a little 5-minute break. And yeah, okay, so we'll go ahead and get started. Imagine you are a PGY1, you're a brand new intern, and you're holding the GYN pager on service, and you get a page. I hope, okay, great. You get a page and it says ED22. You have a 34-year-old female with vaginal bleeding and abdominal pain. And that's all the page says. Usually there's a little bit more information. But you get this page and you have to respond. So, what information would you like to know? You can either come off mute or you can answer in the chat, whatever is easiest. G's and P's, yep. LMP, good. Anything else on set? Okay. Quantifying and qualifying the bleeding and the symptoms, exactly.
Maybe result of the urine pregnancy test.
Yeah, figuring out if the person's pregnant. Perfect. Getting better idea of where the pain is. Good. I think those are a lot of the questions that we want to ask our ER resident about when we call them back. And what are you guys thinking in terms of your differential diagnosis at this point with barely any information? Okay, good. Spontaneous abortion or miscarriage. Uh-huh.
Ectopic.
Ectopic, yeah. Anything non-pregnancy related? PID, good. Great. Yeah, fibroids, endometriosis, maybe, yeah. Ovarian cyst rupture. Okay, perfect. These are really good. I think some other things I was thinking about that we might forget a little bit are like non-like emergent things, right? That people can present to the ER with, like polyp or yeah, or fibroids, like someone said. Yeah. Ovarian torsion, a little bit less related to bleeding, but absolutely with pain and should remain on your differential at this point because that is an emergency. Vaginal trauma, that's great. Okay, awesome. So we have a really good and broad differential diagnosis at this point. And I think often, we captured this too, right? Like sometimes our brain immediately goes to like pregnancy related diagnoses. And right now we have no idea if this person is pregnant. And so it's good to kind of keep your differential very broad and remember all of those things that people may be coming to the ER with as well. Okay, great. And so we finally get a little bit more information. So I'll just read the information out loud. So she's a 34-year-old G2P1 with no significant medical problems. She was really excited to find out about her pregnancy a couple weeks ago. She did start having abdominal cramping on her left side, rates it a 5 out of 10. Vaginal bleeding is light and has been changing her pad every 3 to 4 hours. She had one C-section 3 years ago. She reports regular periods with mild dysmenorrhea, no history of fibroids. Can't remember when her last pap smear was, but did have chlamydia 2 years ago that was treated. Okay. And then here are her vital signs. Great. Her vital signs are here. Overall, very stable. And then here are her labs. Okay. So what would you like to do next? Having this information. Ultrasound, good. Perfect. Maybe even before the ultrasound when you see her. Pelvic exam, good. So doing a physical exam, including an abdominal and pelvic exam. Great. And what are you guys looking for on your exam? We'll start with abdominal. Tenderness. Peritoneal signs. And Valerie, what are peritoneal signs? Yep. Okay, good. So you want to make sure, so like a normal abdominal exam is soft, right? There may be some like moderate tenderness when you push, but there shouldn't be significant tenderness or rebound tenderness, right? Which means that when you let go, then you feel the pain. Um, it should be non-distended, right? And non-tympanic. And so those are signs of a normal abdominal exam. What are you worried about if someone has peritoneal signs on their abdominal exam? Peritonitis. Okay, so inflammation of the peritoneum. And that usually results from like blood in the belly, right? And so, yes, obviously there are all these other like GI like pathologies that can lead to those things. But when we're thinking about someone who's coming in with a gyne issue, I'm worried about, okay, is there fluid in in the belly? Is there blood in the belly? And so that would be really concerning if someone had a peritonitic abdomen. Okay. And then what about on pelvic exam? What are you looking for? Cervical motion tenderness. Good. Yeah. Dilated cervix. Okay, great. So you're going to place a speculum, right? And you're going to take a look. She's bleeding. So you want to see how much is she bleeding? Is there blood like pouring out of the cervix? Are there active products of conception coming through? Then that is sign of like a threatened miscarriage, right? Or an ongoing miscarriage. Um, if there is cervical motion tenderness, that's part of your bimanual exam, right? And so you'll do that after you do your speculum exam. And that kind of gives you an idea of like a similar picture of the abdominal exam. It basically tells you, does someone have significant tenderness of the cervix because I'm moving the pelvic organs around, right? And so that could be related to peritonitis, that could be related to PID or infection. That could also be related to like hemoperitoneum, right? And so that's what the finding of cervical motion tenderness is really telling you is how irritated it is everything around the uterus and the other pelvic organs. Um, and Kandale asks, are we looking to see if there are any fetal parts? So that could be part of it, right? With products of conception. We don't exactly, yeah, Anusha asks a really good question. We don't exactly know how far along she is. We know that she is pregnant. Her HCG here is 4350, right? And so we don't know how far along she is in her pregnancy yet. I wouldn't really expect to see fetal parts unless someone were like further along in their like second trimester, give or take. Okay, so we have a very good exam picture. And then someone else, when we talked about earlier, a lot of people had mentioned ultrasound. What are we looking for ultrasound? Yep. Okay, good. And so a lot of people are saying intrauterine pregnancy. That is the hope. That is the hope. But mostly like, yeah, we want to get the ultrasound so we can localize the pregnancy, right? We can confirm that it's intrauterine or make sure that it's not extrauterine or an ectopic pregnancy. Okay, great. And then when we localize the pregnancy, we also want to know how far along she is, right? So we can also get a better idea of where she is in her pregnancy. Based on kind of her like description of finding out about her pregnancy, I'm expecting that she's somewhere in her first trimester, right? But people always can have irregular periods, et cetera, et cetera. Okay. Great. At this point, how has your differential changed? If it has changed. Yeah, so I would maybe focus my differential a little bit more on those pregnancy-related diagnoses that we had initially talked about. Like, right, like fibroids, ovarian cysts, those types of things can absolutely still be the cause of these symptoms. But higher up on my priority list are like, yeah, ectopic, miscarriage, maybe a threatened abortion, right? Those types of things. Okay. Um, is there anything in this history that I've given you that maybe are ringing little alarm bells in your head? in terms of like what this diagnosis could be?
C-section.
Okay, yeah, what are you thinking there?
I'm thinking possible like rupture or like from previous C-section there was like adhesions or something that's probably going on. So
Yeah,
yeah.
that's a really good thought. And definitely prior C-sections can put someone at risk of a pregnancy being implanted within that C-section scar, right? I think someone had mentioned that in the chat. And so that's what we call a C-section scar ectopic pregnancy, which can be life-threatening, especially if there's heavy bleeding. Um, there's less of a risk of like rupture of the C-section scar early in pregnancy unless you're in like labor. Um, if it's like a normal intrauterine pregnancy. Okay. Someone mentioned chlamydia. Valerie, what are you thinking there?
Well, it says it was treated, but I think regardless of that fact, it does increase your risk for like scarring of the tubes in an ectopic pregnancy.
Yeah, exactly. So, having a history of STIs, treated, untreated, can increase your risk of PID, increase your risk of pelvic adhesions, tubal disease, and ectopic pregnancy. So yes, that's a really good thing to note in her history as well. And then Anusha mentioned, okay, she had chlamydia a couple years ago, but maybe we don't know what her current STI situation is, and that's really important to remember. Okay, and then no last PAP per memory. What are you worried about there, Anusha?
I think that was just going along with the fact that I didn't see any prenatal history. So usually when someone finds out that they have a pregnancy, they go through all the appointments, they go through all the tests and things like that. So my concern, I guess, would be that, we usually check for cervical cancer or things with PAPs, but we can also check for like HPV and all of these other diseases as well. And I just didn't see that on there.
Yeah, so it's kind of giving you an idea of like how well connected she is to the healthcare system right now, right? And where she is in terms of her prenatal care, and it doesn't seem like she's started that yet. Okay, perfect. Great job, guys. So now let's move on to the exam. So overall, your exam is pretty reassuring. She isn't in acute distress. Her abdomen is soft, non-distended. She does have some tenderness to palpation in the left lower quadrant, but doesn't exhibit any signs of um, doesn't exhibit any peritoneal signs. Her pelvic exam shows some dark blood in the vaginal vault. Her cervix is closed. There aren't any evident lesions on the cervix. And your bimanual exam shows a small uterus. There's some left adnexal fullness and tenderness with palpation there, but no cervical motion tenderness. Any thoughts about this exam? If not, we'll move on. Anything that worries you guys? Okay, great. So Anusha says closed os plus left adnexal fullness is more concerning for ectopic, right? I will say, like, and left adnexal fullness may not be something that you will routinely feel with an ectopic. If I do feel that, then I'm a little more concerned. Okay, this might be kind of a big ectopic. But yeah, that is what I was getting at when I wrote this exam. Okay, perfect. Let's move on to the ultrasound here. And so we're going to go through kind of what you would expect to see on ultrasound in general. Okay. Here I'm showing two pictures of ultrasounds. They are two types of ultrasounds. Um, does anyone know what type of ultrasound this on the left is in terms of location? This might be a read my mind question, so it's okay if you guys don't know. Abdominal, great. So this on the left is a transabdominal ultrasound, and this on the right is a transvaginal ultrasound. Um, I always recommend that people, even if you end up in a residency where you may not be doing that many ultrasounds yourself, like if someone is just getting formal ultrasounds ordered, still always make it a habit to look at the pictures because the more you look at them, the more comfortable and the more familiar you get with like reading these ultrasounds. And so transabdominal, you can see it's abdominal because this I don't know if you guys can see my mouse here, but the top part by the logic symbol is kind of flatter, right? It's not as curved as the top part of the transvaginal probe. And so that's how I know that this is a transabdominal. Obviously, the actual picture looks different, right? But if you want to just get a very quick, okay, this is transabdominal, this is transvaginal, that's how you do it. And then for both of these, what can you tell me about the position of the uterus? Is it anteverted? Is it retroverted? Is it midline?
I'll say the introvert.
Anteverted. Perfect. Yeah. So you can see the uterus, right, is facing upwards towards the bladder, towards the anterior abdominal wall, and it's the same here. Okay, so most uteruses are going to be anteverted. Retroverted uteruses can be a little bit more difficult to scan. And so, yep, but both of these are anteverted. And you can see the bladder here, the uterus, the vagina, same thing here, uterus, cervix, and then the bladder would be here. When you're doing an ultrasound for, if you want to get the best picture, you're going to get a better picture transabdominally if the bladder is full because it really helps delineate the uterus. And you're going to get a better picture transvaginally if the bladder is empty, okay? Just because the bladder can look really big on the transvaginal ultrasound and decrease your visualization of the uterus. So usually when we do ultrasound for pregnant patients, for anyone who needs a gyne ultrasound, we will start transabdominally and then do a transvaginal if we need it. Usually in a first trimester pregnancy, you will need a transvaginal ultrasound to get a good picture. Okay, so now this is going to be the ultrasound for the patient that we're talking about. Okay, so this is an ultrasound of the uterus. And I know this is a still image, but let's imagine that this is like, a representative image of the uterus. Usually you want to do like a video scan through so you can see throughout. What are you guys seeing here? Or maybe what are you not seeing here? No baby. Yeah, there's no pregnancy in there. And you can see that there is like a thin endometrial stripe, right? And we actually call this trilaminar because you can see three lines there. There's that line, the bright line, and then the other line. And so that tells you this is like a very thin endometrial stripe. It's not thickened. There's no pregnancy inside the uterus. Ideally, if you are getting the best picture ever, you would get rid of all this negative space here that's not telling you any information below the uterus. And so you would do that by decreasing your depth. And basically, you always want to make sure that like the uterus or um whatever your target of interest is going to be like take up the most space. Okay, so I would get rid of all this extra stuff on the bottom that's decreasing my view of the uterus. But yeah, so there's no pregnancy inside the uterus, but we're not done yet, right? And yeah, Valerie, don't worry. Like the idea of thickened endometrial stripe is somewhat subjective, but yes, this is what I would call a thin endometrial stripe. Um, and so you can't just look at the uterus, right? What else do you have to look for? You have to look at the other structures to make sure that there's not a pregnancy elsewhere, right? Based on her labs, based on her history, we know this person is pregnant. So we have to find a pregnancy somewhere if it's not in the uterus. So then the next thing you want to do is you want to look at the ovaries. So this one on the left, sorry, I should have flipped the order of these pictures because this is her right ovary on the left. And then this is the ovary, this is the left ovary on the right. I'm sorry about that. Okay, so what are we seeing in the right ovary here? On the left. I'm going to confuse myself here. What are we seeing there? Fluid. So there's definitely fluid inside the spot because it's black, right? So black is fluid. Good. And so this is definitely a harder question. Yep, it's a cyst, but what it is it's actually a corpus luteum cyst. And so you will see this very often with people who are pregnant, right? Because the corpus luteum is what's supporting the pregnancy before the placenta develops and secretes its own progesterone. So the corpus luteum is usually like shows up in people who are pregnant, which can sometimes, like people can sometimes look at this and be worried it's an ectopic, but you can see it's in the ovary. It's also has like a rim around it. Those are some signs of a corpus luteum. Okay, what about on the left? What are we seeing? Okay, yep. Here's a gestational sac here. And then what's in the middle of that? Does anyone know? Does anyone know what this little ring is inside the gestational sac? So this here is a yolk sac. Yeah, sorry. I know you guys can't see my pointer. I don't know how to change that. But this little ring inside the dark circle here is the yolk sac. And so a gestational sac plus a yolk sac is like definitive for a pregnancy. Um, and we know that this isn't in the uterus, right? Where do we think it is if this is the ovary? Yeah, so it's in the nexa and most likely in the left tube. And so this is how we kind of diagnose an ectopic pregnancy is we're looking at the nexa, right? And so we're seeing the left ovary here, and we're seeing a mass adjacent to the ovary. It's not part of the ovary, but it's next to it. And that tells us that it's in the nexa, right? And because we can see a gestational sac and a yolk sac, that tells me that this is a pregnancy. Um, and then if we were to put color flow on this, you would see significant blood flow, and that's another sign that this is likely an ectopic. Alan asks if the left ovary is normal appearing. Yeah, this is a normal appearing ovary. When you are looking for ovaries on your ultrasound, some people describe it as looking like a chocolate chip cookie, because it'll look kind of like this slightly hypoechoic circle with usually like small follicles around the edge, and that is what an ovary looks like. Okay. Any questions about the ultrasound?
Dr. Liu,
Yeah.
I apologize if this is a bit of a basic question,
No, no worries.
but so the corpus luteum cyst is the thing that's sustaining the pregnancy, but that's on the right ovary, correct?
Yes.
But
Mhm.
you can still have an ectopic on the left side, even though, like, in my head, the egg that is forming the ectopic pregnancy would have come from the right, because that's where the corpus luteum cyst is. Am I incorrect in thinking that?
Um, so wherever the egg comes from doesn't necessarily always lead to like, oh, I see what you're saying. Um, the corpus luteum, no, yeah, you're right. Maybe this wouldn't be the reality.
I think it's less
Yeah.
common, but
Yeah.
it does happen where, and they've done studies on this, but I think like a third of the time, um, an egg that's ejected from one ovary actually is caught by the contralateral fimbria. And so it actually implants over there on that side, even though the corpus luteum's on this side.
Oh,
Yeah, yeah.
that's
Thanks,
super
Dr.
cool.
Ganti. And obviously these are not the same like ultrasound pictures,
Oh,
just
okay.
from Google. But yes, I think like oftentimes we see crazy things happen that don't like fit the way we think of pregnancy conception. So it does happen and it can happen. And yeah, yeah.
Perfect. Thank you so much. I thought I was thinking about it weird, so I just wanted
No,
to
that's
clarify.
totally fine. That's totally
Thank you
fine.
so
And
much.
that's a really astute question. Okay, great. So oh, actually, I might have given it away. Let me move on to the next one. Okay, so this ultrasound, our patient doesn't have this, but this is an ultrasound picture that would make you more concerned about kind of this person's like clinical stability. And why do I say that? What am I seeing on this ultrasound picture? And it kind of gives it away with the arrows and the caption. Free fluid, yeah. So I'm seeing free fluid here, which makes me more worried that this ectopic is rupturing, right? And so this free fluid could be blood. It probably is blood. And so if I saw this on my ultrasound, then I would like start getting the patient ready for surgery. Yeah. Oh, sorry. Okay, but our patient doesn't have this on her ultrasound, thankfully. Great. So we already answered this. So our diagnosis is an ectopic pregnancy, right? If we want to be really specific, we can call it a left tubal ectopic based on our ultrasound and the findings on that image. So to go over a little bit of epidemiology behind ectopic pregnancy, so overall, it is rare. Okay, it's 1 to 2% of pregnancies. If you work in like a ER setting, it feels like it's more than that because it's one of the common things that we do see in early pregnancy. Um, and there are risk factors. Some risk factors we've already named. Does anyone want to put out more risk factors? We talked about PID, tubal disease, IUD in place. Great. We'll talk a little more about that. Anything else? Those are kind of the big ones that people think about. Prior ectopic pregnancy, right? Venice, you're thinking of bicornual uterus. Yeah, great. Okay, let me just click through all these risk factors and we'll talk about it. So prior ectopic pregnancy is probably the highest risk factor. So 10% risk of having another ectopic after one, and then over 25% after two or more. This is even if you have a salpingectomy after your first one, right? Because we know that when someone has an ectopic pregnancy, it's not necessarily always just because one tube is damaged, but more so that there was some kind of like clinical environment that just created tubal disease more generally. And so, yeah, so having one prior ectopic puts you at higher risk of more. Fallopian tube damage in any sense, I would say probably the most common is PID. Having a history of pelvic or tubal surgery. So if you had like a tubal ligation or something like that, and then ended up getting pregnant, which can happen, or having endometriosis can increase your risk of fallopian tube damage. Infertility is sort of related to that, like tubal disease, right? Because a lot of people have issues with infertility as a result of tubal factor, but having like the embryo transfer itself through IVF can increase your risk of ectopic pregnancy with that embryo transfer. IUD in place, I always talk about this because, it freaks some people out. The reality is, like, if you have an IUD, the likelihood that you're going to get pregnant with an IUD in place is extremely low, right? So if you just look at that, your risk of an ectopic pregnancy is actually lower than the general population because you're just not getting pregnant. However, if you do get pregnant with an IUD in place, your risk of that pregnancy being an ectopic is actually kind of like 50%. And that's because you have something physically inside the uterus that's preventing something from implanting there, right? So it's going to implant somewhere else. And so, yeah, so I always make sure to explain that a little bit, especially when I'm counseling patients on IUDs, because that's something that they hear about and can make them worried about getting that option. And then some patient characteristics are lightly associated with ectopic pregnancy, that being smoking, advanced age, some anatomic abnormalities like having a bicornuate uterus or a didelphys maybe would increase your risk. But overall, those are like less common risk factors for ectopic. Okay. And then just to go over kind of the different locations of ectopic pregnancies. So obviously this one in the red is the right implantation site, right inside the uterus. The most common location for an ectopic pregnancy is in the ampulla of the tube, so right here, so getting close to the fimbria. And that's 80% of ectopic pregnancies. Another common location is the isthmic, isthmus of the tube. And so basically tubal ectopics represent like 90% of all ectopic pregnancies. Less commonly, we have interstitial ectopic pregnancies, which are extremely life-threatening if they rupture, because they're very close to the myometrium of the uterus. And then you can have cervical ectopics, ovarian ectopics, which are extremely rare, abdominal, they can be anywhere, really. What's not here is like a C-section scar ectopic, which is something that I think we've seen more of recently, and we have like newer data about treatment of those as well. But most of the time, you're going to see it in the tube. Okay, so there are two types of management for ectopic pregnancies. One is with medication, methotrexate, right? And the other is surgery. And it's important to counsel people on both options, but sometimes, like we talked about earlier with that ultrasound with the free fluid, there are situations where medication is not really an option. So we'll first go over methotrexate. And you guys are much closer to this picture on the right than I am, but methotrexate is blocks basically the conversion of folate to tetrahydrofolate. And so it targets rapidly dividing cells. That's why we use it in chemotherapy, right? That's why we use it for autoimmune diseases. And that's also why we use it for ectopic pregnancies. And so it targets those rapidly dividing cells in an early pregnancy and helps kill the pregnancy. Methotrexate is an intramuscular injection, and so you would need to know the patient's body surface area, which is not something we usually measure, but that's kind of how we dose methotrexate. And it is relatively successful, but there are failures, right? And so it's important to counsel patients that we're giving you this medication, but it's really important to continue following up because there is a possibility that it doesn't work. And then there are some contraindications to methotrexate. And I kind of think of these contraindications as like absolute contraindications and then relative contraindications. Absolute contraindications, I would not offer methotrexate to. And that includes concern for ruptured ectopic, right? If someone already is rupturing their ectopic pregnancy, then I wouldn't like feel comfortable just sending them home after getting a medication and then following up. So if there's concern, so if someone has like hemodynamic instability, if someone has a concerning abdominal exam or free fluid on ultrasound that's significant, then those are all reasons why I would not recommend methotrexate. If someone has renal or hepatic dysfunction, active pulmonary disease, methotrexate can make all of those worse, and I would not give it to them. And then one side effect that I do talk to people about when I give them methotrexate is the risk of developing like ulcers that can be mild for most people, but more significant for some. And that's because it's targeting those rapidly dividing cells, right? And so we have those same rapidly dividing cells in our mucous membranes, in our mouth, in our esophagus, our stomach. And so someone with like active peptic ulcer disease, methotrexate could make that significantly worse. But people who don't have any history of these things can develop like aphthous ulcers, those types of things as well. And that's normal, a normal side effect of methotrexate. And then lastly, if they can't follow up, right? And sometimes people say they're going to follow up and then they don't. And so you can only do what you can do, but it's important to kind of like emphasize this to the patients when you counsel them. And then some more relative contraindications. These contraindications are more likely associated with methotrexate failure. But if someone like really does not want surgery, you can still safely give them this medication. And so that would be if the ultrasound we saw had fetal cardiac activity. And so in our previous ultrasound, we just saw a gestational sac, right? That black hole, and then the yolk sac, which was that bright little ring inside. We didn't see an embryo or a fetus yet, and we didn't see fetal cardiac activity. If we saw a fetus with fetal cardiac activity, then that tells me that that ectopic pregnancy is bigger, is more developed, and has like an increased risk of both methotrexate failure and rupture. And so that's a relative contraindication. Another relative contraindication is having a higher beta HCG over 5,000, higher risk of failure, and then also having a bigger sized ectopic. So these 3 points are all kind of like, basically they're probably more in like the 70% success rate for methotrexate, right? And so I've definitely had people like, I think my highest beta that someone was like, I don't want surgery was 17,000. And like, you just have to counsel them on the risks. And if they don't want surgery, don't do surgery. But yeah, so those are the relative contraindications. Okay, after you give someone methotrexate, what do you do? So you want to follow up their betas to make sure that the methotrexate is working. So you get a beta HCG on the day you give them methotrexate. They come back on day 4 and on day 7. And so even though we get this repeat on day 4, we're not doing anything there necessarily. And usually this day 4 HCG goes up, which can always feel concerning. But the difference that you're measuring is between day 4 and day 7 to tell you whether or not this methotrexate worked. And there should be a greater than 15% decrease between day 4 and day 7. If it's less than 15%, then that one dose is not working, and you can give them another dose to see if that works. At any point, if like this isn't working and the patient changes their mind, you can proceed with surgery instead. If it's more than 15%, then you're like, okay, great. The methotrexate seems to be working, so we can continue to follow weekly betas. And they should decrease every week until they're less than 5. And it's important that you continue following it because an ectopic pregnancy can rupture technically at any point, at any beta level. And so you want to make sure you follow them until they are no longer pregnant. This is the protocol for like a 1-dose methotrexate protocol, which most people use. If someone's at a higher risk of failure, you can do a multi-dose protocol or a 2-dose protocol. And that's just giving someone 1 dose of methotrexate day 1 and the second dose of methotrexate day 4. And then you would follow them in the same way. Any questions? If not, I'm going to keep going. Okay, so the other management option is through surgery. And so there are 2 options for surgery. You can either do a salpingectomy, which is removing the whole tube, which has the ectopic pregnancy, or you can do a salpingostomy, which is making an incision into the tube and taking only the pregnancy out, leaving the tube in place. Both of these options are done using laparoscopy for the most part. And they're minimally invasive and it's a same-day surgery. So the patient can go home after their surgery is done as long as they're stable and doing okay. Most people, I would say, do salpingectomies when taking out ectopic pregnancies. There is like a little bit of controversy between like choosing salpingostomy. I will say some patients who are really concerned about losing their tube or maybe have already had one salpingectomy may really want you to preserve the tube. However, it's important to know that that tube itself may already be damaged, right? Because the ectopic pregnancy was in there. So there is some concern, like, are you just putting this person at additional risk of ectopic pregnancy? However, like you can do both options and it depends on what you and the patient decide. After surgery, you do not need to do any beta HCG follow-ups if you do a salpingectomy because you've removed the entire ectopic pregnancy, right? If you do a salpingostomy, you should follow their betas until it's under 5 because it's possible you haven't removed the entire pregnancy. And so that's another thing to watch out for is someone would still have to follow up even after getting a surgery if it were a salpingostomy. Okay, and then the patient tells you they'd like to proceed with surgery, and I want to be mindful of time, so we're not going to go over necessarily the informed consent here. But when you're talking about the risks of surgery with her, a laparoscopy is extremely safe. I usually tell people there are risks with anything we do in life, and I go over the same risks I would go over with any procedure. So those are pain, infection, bleeding, damage to the areas around where we are, and then needing to do additional procedures if necessary for their health. Usually, if you have an ectopic pregnancy, if you call anesthesia, it's added on as an urgent case, right? Urgent/emergent based on the patient's like clinical stability. And then lastly, just a quick anatomy review, and then we'll do a little break. And so I think maybe this picture is a little bit better. So this is what you'll see when you enter the belly, okay, and someone who has not ruptured. And so, we, just to give you guys a little bit of context here, right? The belly is insufflated. You've entered via the umbo here, and you can see the uterus. The uterus looks like this because someone's put a manipulator inside the uterus, so that's why it's looking so perky. And then we've also swept all the intestines out of the way, so the patient's probably in Trendelenburg. Okay, so this is like a perfectly set up view, not necessarily the view that you see when you first enter the belly. And we have the uterus here, right? We have the right fallopian tube, which is looking nice and normal here. We have the left fallopian tube, and you see this hyperemic area, right? That's looking purple and angry. And this is the ectopic pregnancy. And this is kind of what it would look like from our ultrasound, okay? It's not ruptured yet, right? Like I don't see any blood in the belly. I don't see any oozing from the pregnancy itself. And so this is a left tubal ectopic. You can see both ovaries are looking nice and normal. And then these are, sorry, I know you guys can't see my pointer. The upside down V there under the uterus, those are the uterosacral ligaments. And then here, like next to the ectopic pregnancy here, that is the round ligament going into the uterus. And so if we were to do a salpingectomy, then we just grab the fallopian tube here, we march from the fimbria to the cornua here, and then we remove the whole tube. And the surgery usually takes like 30 minutes, and then we're done. Any questions about that anatomy? Okay, great. Well, great job, guys. I know that was a whirlwind review of ectopic pregnancy and some gynecologic things that you'll see, but hopefully it was helpful. I think we have time for like a 5-minute break. Is that okay?
Yeah, let's try and come back at 3:55 if you're on East Coast time.
Okay, great.
Okay, seeing as it's 3:55, I'll get started. So the next section is going to be focused on the office. All right. So again, we'll introduce our case. Your medical assistant hands you a slip of paper for your next office patient, 38-year-old female G2P2 with irregular periods. What information would you like to know? And feel free to message in the chat for those who are back from the break. Okay, might need a couple more minutes, and that's okay. Oh, okay. Full menstrual history, NMP. Yeah, these are all really important things. So just a little more context, right? And it's all those things that you guys learned about, either the PQRST or old carts things you learned when you first start doing patient interviews. So this is great information. So this is all the history that you get. So this patient that used to have regular monthly periods until a year ago, and then started having periods every 3 months that were more painful, and for the past 4 months has not had a period. And she does endure some spotting in between periods, usually after sex, and some thicker, odorous white discharge. And she has been mentioning more mood swings, irregular sleep, and feeling tired. Says there haven't been really any changes in her routine or stressors. She does have a new male partner, and they've been having unprotected vaginal intercourse for the last 7 months. She's open to being pregnant, but says she's not really trying. Okay, so got a lot of information there. And then you go into the history portion. So her 2 pregnancies were vaginal deliveries, now 2 healthy children, aged 13 and 15. She never had an abnormal pap that she remembers, but her last one was 13 years ago at her postpartum visit. She has gotten the Gardasil. She has no yeah. And then on to the medical history. She has reflux, sleep apnea, and obesity at the BMI of 33. No prior surgeries, takes just Pepcid, no drug allergies, and no substance use history. So just based on her initial history, what are some of the problems that you've identified, right? Patient's here for a problem visit, and by my count, actually, it's a problems visit because she's got about 7 things, which is the reality often when you're in the office. Great. Dysmenorrhea, so painful periods. Very good. AUB, abnormal periods. Right. Any others? Infertility, unprotected sexual intercourse, right? A risk factor for diseases. The discharge. Good job picking up on that. All right. Yeah, exactly. Yeah, so, potentially some dryness. She was mentioning some symptoms there. Um, so this is the full list of things that I noted. So, she's overdue for her cervical cancer screening as well, which Amisha mentioned. Great. And you guys actually basically got all of them. So now we're just going to tackle them one by one. And sometimes in office you have to have them come back to be able to fully work out all of these issues. But so we'll start with abnormal uterine bleeding. What are some causes of AUB? Okay, someone already knows the acronym. Yes, palm coin. All right, we will get to that in just a moment. But now that we got the history, we're going to get the exam out of the way. And there isn't too much here. There's a very normal exam. The main thing you notice is that indeed she does have some clumpy, thick white discharge, but otherwise normal sized uterus, not too tender. And the rest of the physical exam is without any complications. So you collect some swabs, you send a urine sample for a pregnancy test because you realize, it's been a while since she had a period, and you get a pap smear. All right. So now that you all have already cut to the chase with the palm coin. So this is an acronym that sounds like a crypto they should not invest in, but in reality, it's what FIGO came up with as a way to think about all the different causes of abnormal uterine bleeding, which used to be a bunch of different diagnoses. We kind of clump them together and now think of these as subtypes. The POM aspect is all the structural ones. So polyps, So you think about your skin, right? And normally it's supposed to grow smooth, and every once in a while it kind of blebs out, and that's a skin tag. Similarly, on mucosal surfaces, that bleb might be a polyp. Adenomyosis is when that lining of the uterus, actually the endometrium, is kind of growing into the muscle. Leiomyoma, of course, is a benign smooth muscle cell tumor, and up to 2/3 or more of women can have these. Sometimes it causes pain, bleeding, as does adenomyosis. And then finally, there's malignancy as well as cancer and precancers. So generally, these are all things that you can see on imaging. So it's a little hard to see because these images are small, but you can see a polyp on ultrasound versus hysteroscopy in the top left, below it, some adenomyosis on MRI and ultrasound. You're seeing a gross photo of fibroids there and leiomyoma, and then you have the malignancy, gross and microscopic. Then flipping over to the non-structural causes, coagulopathy, you're more likely to see this in someone who has primary AUB, so like teenagers, because you're thinking about bleeding disorders like von Willebrand, for example. But it's still something to think about. Ovarian dysfunction, and we'll go into that a little more detail in a moment. Endometrium. This is confusing because all the things we already talked about, endometrial polyps, we talked about adenomyosis, which is endometrium invading to the myometrium, we talked about endometrial hyperplasia. But this E is more so for like microscopic things, so like chronic endometritis, for example. So inflammation or infection of the endometrium that you may not see on an ultrasound. Iatrogenic, right? When people on birth control, it changes their periods, and we expect that. And then finally, the catch-all idiopathic or not otherwise classified. So then back to AUBO. So when we think about the normal axis, the hypothalamus makes GnRH, which then signals to the anterior pituitary to make FSH and LH, which then stimulates the ovary to make either estrogen earlier in the cycle or progestin later in the cycle. And when you're thinking about disorders that affect that process, one of them is polycystic ovarian syndrome, right, which we generally attribute to more male hormones or testosterone. And there's different criteria. The PCOS Society, for example, has developed some more criteria beyond just the Rotterdam, but this is kind of the basic set that you're most likely to encounter. What you're looking for is for two of the three. So oligomenorrhea, which our patient has, right, periods that are spaced out. Signs of androgenism. So this can be lab signs like an elevated testosterone level or clinical signs like facial hair growth. And then ultrasound findings. So an enlarged ovary with numerous follicles would be classic. Other things that can affect this, of course, are thyroid hormones. And so both hypothyroidism, which can suppress ovulation, as well as hyperthyroidism, which affects follicle maturation, and then prolactin, which suppresses gonadotropins when elevated. So this is more the directly impinging on this pathway. But there is another important endocrine organ that affects periods, and that's the adrenal gland. This is a real throwback to your preclinical years. And you remember from the outside in, you have that salt, sweet, sex layers of adrenal gland. And so either you can have a variation of PCOS where the high male hormone is not testosterone, but it's actually the DHEA sulfate. And you can also have something like a non-classic form of congenital adrenal hyperplasia. So the classic form is what they screen for, and it's more severe, right? You screen for as a newborn, it has salt wasting, things that you'll catch sooner. But non-classical can be adult onset and really show up initially as abnormal bleeding or infertility. So it's good to have that on your radar because it has symptoms very similar to PCOS. And again, when we're thinking back to our patient's exam, she didn't have any hair growth or acne or anything of that nature. So she didn't really have clinical signs of androgenism, but it's still helpful for us to think about PCOS and the differential when we're deciding on next steps in terms of labs and imaging. So like we talked about, the structural causes, we'll do an ultrasound for. We're going to hold off on going on to coagulopathy just yet, but some additional labs like an FSH and E2, basically you're trying to see, do the hormone levels in the follicular phase line up with what we would expect? And then TSH or thyroid hormone testing, prolactin, testosterone, the DHA sulfate, and 17-hydroxyprogesterone, which is what's going to be elevated if you have that more common congenital adrenal hyperplasia, just the 21-hydroxylase deficiency. AUBE, again, this might be something you test for with endometrial sampling. You can actually send it for a specific stain for plasma cells to gauge the amount of inflammation if you're trying to diagnose chronic endometritis. But you're going to focus on the ultrasound and lab work for initials. And because she is having heavier bleeding, you also want to check in on anemia. This is a patient who's talking about being tired, right? So great. So now on to the next diagnosis was our differential for pain with menses. What are some causes? And we already mentioned a couple of them. In fact, Anusha's last message, fibroids and adenomyosis, both of those can cause painful periods, certainly. Can we think of a few more causes? Endometriosis. Yeah, that's a really big one. All right, polyps sometimes. Yep, infection, very good. Yeah, absolutely. These are all terrific. So the most common is primary dysmenorrhea, which is just recognizing that some people have more painful periods, and you might not be able to pinpoint a specific reason. Of course, not exactly what our patient, who didn't have painful periods before might be experiencing, but something to think about. And the mechanism for this pain is basically that too much prostaglandin is produced, leading to more painful contractions. So that is a clinical diagnosis. Endometriosis, which some of you have mentioned, is kind of this what is often called a sister disease to adenomyosis. So if adenomyosis is the endometrial lining growing into the muscle wall of the uterus, endometriosis is it growing beyond that, either outside the uterus or anywhere else within the pelvis and abdomen potentially. So sometimes imaging can catch it, but often you might need laparoscopy to actually see that. Adenomyosis and fibroids, we've already talked about. Pelvic inflammatory disease, which we talked about in the GYN section, is potential cause for a patient who's coming in with abdominal pain. And what you're thinking about there is an ascending inflammation that leads to chronic inflammation and scarring throughout the genital tract. So cervical motion tenderness is a really useful clinical sign. And if you think back to the exam for this patient, she didn't have that, but it's always good to keep that on the radar. Cervical stenosis, sometimes more common in postmenopausal patients, where a narrowed cervical canal can occur, and sometimes some fluid gets caught behind it and leads to pain. And then in endometrial polyps, like we talked about as well. Now, you want to work up these potential causes, but you also want to think about things you can do to help the patient's pain. And so here's just a short list of options for a patient who's having painful periods. So some of these are anti-inflammatory medications, and NSAIDs in particular are useful. And the reason for that is because they directly work on the prostaglandins, like we talked about, which are the main mechanism for the painful periods. And by decreasing those levels, you actually have improvement in the pain, but also up to a third less in bleeding. But this is for taking scheduled NSAIDs, basically like 3 times a day throughout the time course of the period. Then you have a couple different types of hormonal contraceptive options that also work, mostly by suppressing ovulation. And then you have some non-pharmacological things. So heat therapy, exercise, and even electrostimulation are all things with some evidence that they can be helpful. So now you're on to the next diagnosis. I mentioned that you had collected some vaginal swabs and a pap smear. And in addition, the tests that you want to get are here bolded, are HIV and syphilis, because those are blood tests. Now on to infertility. So the question is, does this patient meet criteria? And the reality is, yes, she does, because over the age of 35 and has been having regular intercourse for over 6 months. Below that age, it would just be over 12 months. So now let's talk about the evaluation of infertility. So a few different causes can be at play. So when you're thinking about your reproductive system, start at the top with the ovaries. So one is thinking about the number of eggs. So the oocyte quantity, the other is the oocyte quality, which declines with age. And then finally, there's the whether or not the ovaries are actually sending out eggs. So This is ovulatory dysfunction, or AUBO, which we talked about. Then you think about the tubal factor aspect. Is there any kind of tubal scarring? Are those closed or open? The uterine cavity factor, which is all their structural causes of AUB. So you can see how this evaluation kind of overlaps with the evaluation of the AUB in a few different ways. But some important other things you want to get, of course, are thinking about male factor. Contrary to a lot of historical stigma, about half of infertility is attributable to male factor. And then also thinking about genetic causes, especially in patients who are having recurrent pregnancy losses. So just going to click through here. Stuff I mentioned. A few things to note is that AMH is something that is often used as an assessment of oocyte quantity. The best evidence is for its use with assisted reproductive technology, so IVF, rather than as a general indicator, but it's still a lab that we often obtain. And then some potential ways to look at tubal patency include either a saline perfusion study or a hysterosalpingography. So one is ultrasound and looking at fluid bubbling through the tube versus the other is injecting dye into the uterus with X-ray imaging. Genetic causes can be both aneuploidy or triploidy chromosomal things. Balanced translocations, right? Balanced translocations in the parents can become unbalanced and cause pregnancy loss in fetus. Then you have other things like Fragile X that can cause premature ovarian insufficiency. And there are genetic causes for coagulopathies as well. Right. A few other less common things to think about, immunologic factors. So maybe autoantibodies, antiphospholipid syndrome can often cause recurrent pregnancy loss, anti-thyroid antibodies, some surgical infections like prior scarring, infectious diseases. We did talk about the STDs and things. Drugs, so certain medications can certainly affect your ability to get pregnant. So contraceptive medication, certainly, chemotherapy, steroids, and as well as some psychiatric and recreational drugs. Finally, psychosocial factors and lifestyle can also impact infertility. There's a lot of information, but in the end, the most common cause is actually unexplained infertility. All right, so you think through all of that, and then you actually get the results from that urine sample you collected and actually came back positive. So now you're going to plan with this patient to get a blood test, and that because she has irregular periods, so it's a little hard for you to gauge exactly how far along she might be. And so you want to see if it's high enough that you might see something on ultrasound. So she gets the blood work done, and 2 days later, you get a bunch of results. You get her blood work results as well as the results from the things that you already had collected. So you see that she is positive for both yeast and BV, so you treat it with the appropriate medications, fluconazole, metronidazole. But you also got a pap smear that showed AGC, whatever that might be. But the patient's kind of scared about it, having seen the pathology report. And, between that and everything else, she's not sure she's ready for pregnancy now. So she wants to know about her options. And so that kind of leads us to options counseling. So when we talk about for any pregnancy, there's kind of three different categories of options. There's expectant, and there's kind of two categories of this. Either you've diagnosed a pregnancy loss or you've diagnosed a live pregnancy, right? Expectant management for a live pregnancy is going to be like prenatal vitamins and doing prenatal visits versus for a loss, you're going to be talking about the time frame that you would expect contractions and bleeding to begin and following that up accordingly. Medical termination. So the most effective regimen is a combination of mifepristone and misoprostol. So generally, medical termination is offered up to 10 weeks and then is most effective before 7 weeks. And it can be 95% effective for that protocol. But if there's limited access to mifepristone in your area, a 2-dose misoprostol regimen, while slightly less effective, is still works for most patients. So the advantage of this is that it's kind of patient administered. So And so a patient can do this from the comfort of their own home, and they might appreciate that it's less invasive, but it does involve pain, bleeding. And so you want to make sure you've thoroughly counseled on that. And there's a possibility that the miscarriage doesn't complete. Then surgical termination. So that would be either a manual vacuum aspiration for first trimester cases, which doesn't require a whole anesthesia team, versus an OR procedure like a dilation and evacuation, which can be done up to 24 weeks. Generalists might do it in the first trimester, and you might reach out to your wonderful complex family planning colleagues once you get to the more challenging second trimester cases. So it's 99% effective, and a lot of patients appreciate it because they have the confidence of coming out of the OR knowing that this is behind them. But there are of course anesthesia risks and surgical risks involved. And then the last option I didn't quite mention, but if you have a diagnosed loss, or a patient is far along enough and intends to terminate pregnancy, you can do labor induction as well, which might allow for grieving for patients who would like to do that, or a whole autopsy if patients are so intrigued. All right. Finally, we got a pap smear. So how are we going to follow up on these results? Well, generally speaking, once you get a pap smear, you're generally thinking, if it's normal, then you just come back in 3 to 5 years, depending on how old the patient is, and what kind of screening you got done. But if it's low-grade disease, because low-grade disease often heals on its own, you might just do a follow-up smear in 1 year, versus high-grade disease is when you'd consider doing a colposcopy, which is when you're going to be looking at the cervix in more detail. And we'll get to that in just a moment. And so here I've got a diagram of the progression from normal cytology all the way to invasive cancer. But wait, your patient didn't have any of those things, though, neither low nor high-grade disease. She had atypical glandular cells. So what is that? So what we say here is that most cervical cancer is squamous cell carcinoma, over 80%. But there's a small percentage that is adenocarcinoma. And that's why this is particularly important to recognize that if she has these abnormal type cells, it could be indicative of this less common form of cervical cancer, where instead of those squamous cells, more glandular. However, it may not be necessarily a cervical cancer or cervical precancer. It also could be a benign cause that leads to this, or it could be something higher up in the uterus, in the endometrium, that you're just catching on your pap smear. So these are all parts of the differential there. So after you make this whole plan, the patient calls and lets you know that, while she was thinking over her options, she actually started having heavy cramping and bleeding on her own and did pass some tissue. Now, that you were saying, the patient has already expressed that she might be interested in continuing this pregnancy. So it is, so you were like, oh, do you want to come straight into the hospital? And she says that, I'm out of town right now, and I understand that I might have miscarried, and that's okay. And she did feel like the pain was managed with the more scheduled medications that you had talked about when talking about her period management. So she wants to keep her existing ultrasound appointment, but she will get blood work and see you for colposcopy. That's a day when she comes back. So now you have this blood work, and you can take a moment to look through it. You can see it's all the various blood tests that we talked about, assessing potential causes for both infertility as well as abnormal uterine bleeding. So key things I'm looking at are, it looks like normal thyroid function, prolactin, no evidence of any adrenal disorders. The follicular ranges are what I expect for a premenopausal patient. AMH is above 1. And she doesn't have any anemia. So actually, this is all a normal studies, which is excellent. So then you follow up that atypical glandular cell with a colposcopy procedure. So this is what you're doing. You're using a speculum, taking a look at the cervix, applying acetic acid or vinegar, and looking for aceto-white changes to see if there are any abnormal cells. Now, because of the atypical glandular cells, it can be indicative of something higher up, like an abnormality in the endometrium, you want to do a simultaneous endometrial biopsy to sample the cells from inside as well as outside. So basically, for your procedure here, you're doing three different parts, right? So one is to collect cells from the outside of the cervix, one to collect endocervical cells, you're going to do an endocervical curettage, and then finally the endometrial biopsy to get cells from the highest point. And so with all of that, you'll have all the additional information you need. Now, colposcopy is often done in the office, but you should always have a conversation with your patient about the pain involved and whether pre-medicating pain makes sense for her. So this can be both prescribing medications to help with pain or anxiety, like single doses of stronger medications like benzos to help with getting through the procedural pain, or as well as local anesthesia methods, like, for example, a paracervical block at the time of the procedure. All right. So then you remember that she got her ultrasound, and well, a lot of words come in that report, but you can see from the impression that the main thing that they're picking up on is a thickened endometrium and a simple right ovarian cyst. And as Dr. Liu mentioned, we always want to take a look at our imaging. So we take a look at the ultrasound, and you can see that, yeah, that's a pretty thick endometrium. That's like half the ovary in this case. So it's a bit of a hazy image. And then finally, you have your colposcopy results. Benign on the ectocervical biopsies, benign in the endocervical epithelium, and then the endometrial biopsy shows hyperplasia without atypia. So all in all, you have a thickened endometrial lining and now a diagnosis pathologically of hyperplasia. So now when we think about endometrial hyperplasia, two different subtypes, the with atypia versus the without atypia. And it's important that the pathologist makes this distinction because they really affect the risk of progression. With atypia has a much higher chance, up to 40% in cases of progressing to endometrial cancer, which of course is now the most common type of GYN cancer in the United States, versus without atypia, which is much less likely to progress. It just has to do with how normal the cells look under the microscope. So without atypia, you might just be doing hormone therapy to help thin out the lining and to treat that hyperplasia, versus if it's atypical hyperplasia, you're concerned about the higher risk of progression. So more definitive therapy could be considered, although it depends on your patient's pregnancy goals. So you always want to have that conversation. So some key risk factors that could have been a part of this. Basically, anything that causes unopposed estrogen can cause that lining to thicken. So over time, of course, age is the number one risk factor for any cancer. And so carrying more weight, because the adipose tissue does produce estrogen, can be a key risk factor, as does polycystic ovarian syndrome. And there's also connections to diabetes and certain medications, like estrogen-only hormone therapy. So after a full conversation about all those causes, your patient said, let's do intrauterine progestin. So you decide to do it in the operating room. So you do a DNC procedure because you have that thick lining. This way you get to take off some of that lining, send it to the lab, and then place the IUD at the same time. And she recovers really well. The post-op visit, you get endometrial hyperplasia with atypia again. And what you're concerned about is it possible the biopsy missed a focal area that has more progressed disease, and thankfully it did not when you did the curettage. The other thing you always were thinking about when you have that thickened lining is whether this patient just miscarried. Is it possible that that's leftover products of conception? And so having this pathology is helpful to rule that out too. Last thing that the patient mentioned was she had some more mood swings, was getting tired, and it can be really easy when you have so many different problems to lose sight of that aspect of it. But even though this patient's only 38, these symptoms can begin in the late 30s, so 10 years before the onset of menopause. And sometimes some of those mood and symptoms are the earlier ones, and sleep symptoms are earlier. And what you'll notice is they do overlap with other conditions like depression. So it's really important to screen for mood disorders and things that could be at play as well, and then work through these issues. Okay. Now, just the last couple things in the infertility evaluation, we talked about the importance of assessing for male factor as well as tubal patency. So you get a normal semen analysis report and you see that the tubes are open. So now you offer the patient the ability to follow up with RAI to discuss future fertility because that's an interest of hers. But she says that it might be a little too difficult for her now and wonders if you can do any kind of office treatment. So you naturally say, well, I want to make sure that your endometrial hyperplasia is cured first, and then we can go down that road. So generally speaking, if you have a repeat endometrial biopsy at 6 months that it no longer shows any abnormal hyperplasia, then if the initial diagnosis was hyperplasia without atypia, then after 6 months, the patient could try to get pregnant. Now, if it did show atypia, and you're trying to do progestin, high-dose progestin therapy to treat it, you should really wait for 2 successive 6-month biopsies before proceeding with fertility treatment. So you have a repeat ultrasound that shows an IUD in place, a thin endometrium. The patient was well treated. So now you know that you can take out the IUD and plan for treatment. And the patient has worked on reducing some of her other risk factors by working with a nutritionist, has lost a small percentage of her body weight, which is when you're having these conversations about weight, you want to try to do it in the least stigmatizing way possible. Just talk about how small changes can have an impact for fertility and health and really connect it back to the patient's health. Because unfortunately, a lot of patients will have heard attempts from doctors to kind of connect everything back to their weight or to make them feel shamed about it. And that's something you really want to avoid doing. So after that, you go into planning for an ovulation induction cycle with letrozole. And that has to do with the fact that there's some evidence that letrozole compared to clomiphene citrate is a little bit more effective. And I have a diagram here for you to look at after the fact. I don't want to take up too much time, but generally speaking, these are 2 of the main ovulation induction agents. Letrozole is an aromatase inhibitor versus clomiphene citrate, which is a selective estrogen receptor modulator that acts up in the brain. So with that letrozole acting.
It'll be my face.
Hi, sorry. Does someone have a question? Okay. Yeah, so the letrozole can be more effective and with fewer side effects for many patients. And so you plan for a few cycles before saying that, really at that point, after a few cycles, the risk of continuing to try has a lower success rate. So progressing to IVF is highly recommended. Right. So you do the office cycle, 6 more months later, you see this on ultrasound. Does anyone want to type the diagnosis into the chat? All right, marvelous. You nailed it, Valerie. Yes, excellent. All right, so that is the end of our case. I just had a few last general tips for all of you as you're going into your intern year that I want to try to wrap up in the next minute here. So first off, there's a surgical boot camp earlier this morning. So the past years, I've helped out with that. Our review is very content focused, but that is an excellent one to learn about just general skills of being an intern. Then some thoughts about what residency is like. I was trying to think about the best way to think about this. So I would say that if that's medical school, then residency is taking that knowledge and you're trying to now put out fires all over the place. And so then next thing is thinking about how you prioritize things when you're a resident. I would say that remember that patient care is always the first responsibility. And then the big power that you have as a resident on day 1, you haven't learned anything more than you knew as a medical student, is that all of a sudden you have this incredible power of putting in orders that make things happen. So I think that you're going to quickly realize that that's something that nurses will be asking you for orders and things. And it can be difficult because maybe you're in the middle of a note and you're like, don't want to lose your train of thought. So you might have related to a particular character, Dr. Santos on the pit, who has to go through these challenges. But it's really important to remember that um, that you're kind of prioritizing these different things and maybe writing some notes along the way so you're not forgetting about some of the things that you want to be keeping track of and maybe have to go back and document a little bit later. Imposter syndrome. You probably have already experienced it at some point in medical school. And it can be really tough in residency just because um, that first few months, everyone is going to be on different rotations. So like one of your co-interns is going to have a lot of labor delivery up front. They're going to have like 50 deliveries. You're going to have like 6, and you're going to feel like I'm so behind. Will I ever catch up? You will get there. Everyone evens out. The programs are made because they know that they can meet all these numbers. So do recognize that everyone's on a different trajectory, but you all reach that destination. Remember why you're doing this. I think that residency, it's very easy to get burnt out, especially in OBGYN residency, but you're all picking this field for a reason. Maybe it's the reason your personal statement, maybe it's something that didn't lend itself to a personal statement, but whatever it is, the reality is that you have your reasons, and if you even write them down, just to remember that on your worst days that you pick this because there are absolutely incredible positive things and validating things about this career. Which brings me to being kind to yourself and others. For some people, one of these might be harder than the other. It's easy when you're sleep deprived to snap at people, but it's also really easy to, you get a lot of constructive criticism and maybe not so constructive criticism as a resident. So trying to make sure that doesn't affect your self-esteem is really critical. And last thing, today is National Pet Day. So for those with pets, I enjoy celebrating. All right. And so we can take another break.
I think for sake of time, we'll just roll straight into our last part and have Dr. Gambala take us to the finish line. Thank you so much, Dr. Ganti.
All right, so now our patient is pregnant, so we're going to go through a little bit of obstetrics with the case. But I did want to tap into the idea of dating and thinking about the dating criteria. You should be able to look at this table very often throughout your residency. I still have to remind myself because it got very complicated in the past. It used to be, oh, if it's off by for in the first trimester, second, and third, you just had to remember so many days. But now it's because ultrasound has become so exacting, we are able to be more specific with if it's more than 5 days. And this is really kind of funny. So when you remember these numbers, it's the more than. So when you get your crown rupture length from your ultrasound, you want to see that it's, does it match what her EDD is by LMP? And then if it's over 5 days difference, then we would be assigning it according to the ultrasound. So this is just something to keep in mind because dating is extremely important when it comes to managing pregnancies. And then when it comes to the best estimation of dates, ultrasound will always, at this point, trump everything. And the most accurate is when it is in the first trimester, so less than 14 weeks. If the patient had assisted reproductive technology, then obviously they will provide an EDD for us. And the most important thing to remind yourself is like what is considered suboptimal dating. And really, it's if you've never been able to confirm by ultrasound at some point prior to 22 weeks. So even if they didn't show up until 18 weeks for their first OB visit and then didn't get their ultrasound for anatomy until 21 and 3, let's say, or even 6, that's still considered good dating. And the dating is really important because when we talk about just laboring and when you want to deliver, that's really going to drive how easy you feel about someone coming in labor and having labor symptoms versus because if they're preterm versus not, then that's where you start getting more worried. And as an intern, you're going to run and find someone to help you because you're like, oh, wait, this is not just a full-term pregnancy. And that helps drive decision making and counseling on whether or not a person can have an elective induction versus medical inductions. As you know, things change quite often, especially in the outpatient setting. As you're seeing your patient, things can develop where you actually schedule someone for a medical induction due to obstetrical indications like hypertension, diabetes. Or even for the fetus, if there's any fetal indications, let's say now that I'm thinking about this, there might be certain situations where you have to schedule their delivery because you want all the services to be available. And so really the dating is extremely important. I remind the team, even though we schedule different people for different induction dates or just to come in for delivery, the team and everybody is responsible for verifying that, oh, this is appropriate, right? Sometimes we'll have patients come in and they're scheduled, but then it turns out when someone looks at their ultrasound or digs into their chart, they find that this patient is not actually 39 weeks, they're only 37, and there was no medical indication for the delivery. So then they have to be rescheduled. All right. Some nomenclature just to review really quick. For research purposes, these started popping out as far as like how can we describe early, preterm, and late. And then the powers that be decided, you know what, let's actually also extend that into the term gestation. So I just added here the late preterm is when they're 34 weeks to 36 and 6. But then term is divided into 4 categories. So we do like to know that patient is above 37 weeks and they might be in labor. Then we're like, take a deep breath and like, oh, great, they got good dating. It's a term baby. Outcomes will be easier to deal with. In fact, usually they don't necessarily require NICU to be there, but they just have a transition nurse. If they're early term, that's suggesting that there's still less than 39 weeks. Usually early term means that you are potentially delivering if you are inducing because of some kind of medical condition. Term would be 39 weeks to 40 and 6. And then late term, as you see there, is 41. It's basically the 41st week. And then post term is now when you realize that they're 2 weeks beyond their due date. The importance of knowing the exact dating and where they fall is also because we realize that there's increased respiratory morbidity when it comes to the lower end of early term. And then actually, as we get further along and depending on the maternal age, even or even maternal conditions, there's difficulty with stillbirth rising as well as that placenta just becoming insufficient as it's getting older. And so there's great graphs to help counsel patients, especially those that are like, no, I want spontaneous labor to happen, and they're now in their 41st week, to review and show them that, with increasing weeks, the risk of stillbirth is high. All right, so your pager will only say this because they can't put all the information about a laboring patient into the screen, but it says basically just call OB triage. There's a patient in labor. So you call OB triage to speak to the nurse. Like, what would you like to know? G's and P's. Great. You definitely want to worry if there's someone in labor that's like a grand multip. Ruptured membranes, awesome. Leakage fluid, bleeding, fetal movement. Great. All right. How far along on the date? Perfect. How close are the contractions? All right. So when you receive that page, you have to remind yourself too, where's the page coming from and how does the nurse know that they're in labor? Good. Great, Emmanuel GBS. So we're starting to think about like, preparing for labor and knowing whether or not they have prenatal care and if you have any records. Awesome. So a lot of information. So when you call and you speak to the nurse, you probably will get a report from them. It depends on your institution and how teams work. but hopefully they'll hand off to you something, right? They'll give you like the situation, background, and maybe their overall assessment. But the biggest thing to note here is weeks gestation. So this is what you get from your conversation with a nurse. It's a 35-year-old G3P1102 at 40 weeks gestation, complaining of regular contractions, no bleeding. She reports good fetal movement, no leakage of fluid. She's received prenatal care, which is great, from Dr. Pam, which she reports was uncomplicated, and her history is all vaginal deliveries. It does show there, just as a reminder, with the P's that, she had one preterm, but they're both living. And then she denies any bleeding, as we mentioned, and or hemorrhage during those prior pregnancies, as well as any NICU care. So that's helpful. All right, so you go see the patient at the bedside. As always, you should do your review vital signs and do your physical exam. And so what would you look at? What's the biggest thing with the vital signs in a laboring patient? Wow, that's fast. Okay, great. So blood pressure. Excellent. So here are your vital signs. No, she's afebrile. Her blood pressure is slightly elevated. She has a pulse that's appropriate. And then you're looking at the strip and you've decided it's a laboring patient. So you're easily looking at it and saying that it's fetal heart tones category 1. Okay, so just by looking at your pager, talking to a nurse, the biggest thing when it comes to labor and delivery and being the resident on call or managing for that shift is that you really want to just pay attention to, is to the gestational age, right? And like making sure it's accurate. So this is extremely important because if they're in active labor and very uncomfortable, but they're preterm, you better be calling NICU right away to come join you. You might want to also have anesthesia available. But it's a scenario where if you realize that they're preterm and are in the window where they should receive antenatal steroids, you can get at least one dose of steroids in, and that might make a huge difference for that preterm infant. In addition to getting magnesium sulfate on board, because that would also be part of management for a pretermer, in that you're going to provide some neuroprotection for that preterm baby. All right, so then when you look at your OB history, that's extremely important in the triage setting, because if they're laboring and you get that they've had C-sections, then you have to decide whether or not you need to prepare them for a repeat, or if they've already had consultation during their prenatal care, that they might want to have a trial of labor. Either way, you want anesthesia on board immediately, just to be prepared to either provide the epidural for labor or to go to the OR. And it's my favorite question to ask when they call me and tell me about a patient. I'll always say, like, when did she last eat? Because that's extremely important as well. If it's an emergency, of course, you're going to go to the OR regardless. But if you can, and you can, even though someone's laboring, you want to do things safely, and then you might have to actually wait a few hours before going to the OR. So when you confirm or know that they have leakage of fluid and ruptured membranes, what should we be thinking about? We certainly want to be concerned that, is there any risk for a cord prolapse, which you'd be able to palpate if you're doing the vaginal exam. But you also want to be concerned of infection. So like, how long have they been ruptured, if they can even tell you that? Maybe it turns out they thought they were just leaking, but that was normal, or they didn't know, they thought it was urine. But they've been ruptured since the day before. So certainly infection is going to be on the back of your mind as you're laboring this patient. Additionally, you would like to make sure and confirm, was that really a head that I felt when you do your cervical exam, and using the bedside ultrasound to confirm that. Last but not least, you don't have to use a sterile glove all the time to do your cervical checks unless they're ruptured. Then you want to, of course, limit your checks and make sure that you're avoiding introducing any kind of infection. So you would use a sterile glove at that time. And then if they tell you that they're having some bleeding, then you have to decide, what is this bleeding from? Is it normal? Is it just from cervical change? The concept of bloody show, it really doesn't happen like a ton, but everybody reads about it and they think like, oh my God, did I lose my mucus plug? Am I having bloody show? You might be able to see that as they get further along in dilation, but you certainly also want to remind yourself when you ask questions about their prenatal care, did they have any abnormal placental pathology? So, asking them specifically, did anybody ever tell you that there's something wrong with your placenta or that you have a previa? Because you definitely would not want to do a cervical exam if they have a previa. Most times, our patients are really drilled, that information is really drilled into their head, so they'll say that right away. So, because they know it's an emergency. If they show up in the emergency room or being checked in triage, they'll say, I have a previa. And providers should be adjusting their decision making and exam, right? So they'll most likely just do a speculum exam. Okay, so vital signs are vital. I can't stress that enough. Thank you to everybody who was like, if I looked at vitals, I'd be really paying attention to her blood pressure. And in this instance, it is in the mild range. So, what other questions would you ask? You certainly want to say, have you ever been told you had higher blood pressure before? You're engaging with the patient versus the computer if you can. So, at some point you can go back and look at her flow sheet to see what her blood pressures have been in her prenatal visits. But you do want to ask some questions to assess if there's any risk that this could be preeclampsia, right? So the headaches, blurry vision, the right upper quadrant pain, and then, of course, any acute onset edema. I love it. All right, so next steps. We'd want to admit this patient, right? She's 40 weeks, she's laboring. You agree that with a nurse, but now with the blood pressure, you want to go ahead and work on making sure that there's no evidence of preeclampsia. You'd review her prenatal labs, check that GBS status, as someone mentioned in the chat. And then you may plus or minus decide whether you want to augment labor. But remember, are they really a candidate for labor? So just thinking of those contraindications. And then confirming presentation. Okay, so let's talk a little bit about hypertensive disorders. You can have chronic hypertension, of course, but in the pregnancy period, you can have gestational hypertension that develops, but that can also turn into preeclampsia and then preeclampsia with or without severe features. And then ultimately, that hypertensive disorder can lead to eclampsia. We're just going to touch on it just briefly. The blood pressure of greater than 140/90, the thing to remember, even though you do a preeclampsia workup at that moment, you're not going to make the diagnosis until you get another blood pressure that's 140 greater than 140/90 at least 4 hours apart. Now that could easily mean that checking the flow sheet, and you might see that she had a blood pressure that was on the higher end in the clinic setting, and then now when she's presenting in labor, she also has one. So that would be your 4 hours apart, and you can make that diagnosis already. But these are the things that you can review with your patient, and you should be reviewing when you're in your prenatal visits. But here, when you see her in the labor unit, it can be a little tough because if she's in pain, then is it pain because she's actually laboring? Is she having nausea or vomiting because she's laboring? So sometimes it can be a little difficult to decipher these truly symptoms. But the headache is really important because neurologic symptoms will automatically throw you into severe preeclampsia because that feature is considered severe, even if your blood pressure is actually normal. So neurologic symptoms will trump everything, even proteinuria or the elevated enzymes. So as part of the diagnosis, though, the focus really is on that blood pressure and then looking for proteinuria, whether it's 300 milligrams in 24 hours, if you can actually get that 24 hours of urine, if you can wait, versus just doing a spot protein creatinine ratio. Some people will say, well, Dr. Gambala, it was only 0.28. Well, it's probably going to be 0.3 if you checked it again 4 hours later, right? So you certainly have to decide, like, it's not perfect, but you're looking for trends. And so you might find yourself actually repeating your workup in the next 4 hours while they're laboring. All right. So diagnosis and management. Once you diagnose preeclampsia, the management is delivery. Just keeping in mind gestational age. We'd really like to get our babies to do well. And this is the part of obstetrics that I love, and that's why I did maternal fetal medicine. But you're just balancing that, right? You want to make sure that the mother is going to do well as the baby. And sometimes that might mean pushing their gestation further if you can. That would obviously be in the hospital setting. But if you're already at 37 weeks, then you would just say, hey, it's time to deliver. The baby's going to do just fine. When it comes to severe, when you have severe features, then you might want to push it a little bit further if you can. And that's where MFM comes into play, where they can help kind of make people feel more comfortable and get to 34 weeks. But sometimes you're just not going to get there. And you can have patients with really severe features and that need to be delivered as early as 28 weeks, sometimes 26. It's not great. And then last but not least, there's eclampsia or HELP. And when you diagnose that, it is delivery as soon as possible, right? This is not going to reverse itself. It's not going to get any better. You would have to deliver that baby with the placenta, and it should, and then the mother will start to recover. So just as a reminder for HELP, hopefully everybody really knows it's hemolysis, elevated liver enzymes, and low platelets. When I say as soon as possible, I purposely did not put a type of delivery mode here because it depends on the providers. It certainly depends on the patient's history as well. But there are occasions where you can deliver a patient with HELP vaginally. I have done it before. But it's limited in that, if your platelets are low, then anesthesia might say, okay, well, you can do that, but I can't give her an epidural, right? Because they wouldn't want any bleeding into the dural space. So there are some opportunities, even though you guys might see C-sections happen pretty often, it's not like it has to happen immediately. So when someone's seizing, for instance, in eclampsia, you want to make sure that the mother is actually stabilized before you proceed with further decisions on delivery. Last but not least, to help with seizure prophylaxis, if they aren't in the eclamptic phase, is the magnesium sulfate, and we like to continue that 24 hours postpartum. Oftentimes, when you're working them up and doing looking to see if they do actually have preeclampsia, with or without severe features, we usually have magnesium on board. But then, if they look like they stabilize, we tend to stop that because you can't keep someone on magnesium for days on end. All right. So here's a chart that you'll probably see and refer to, although I feel like everybody falls into some kind of risk factor and everybody should be on a baby aspirin. And that might be a future recommendation at some point. But these are the risk factors in patients that develop preeclampsia. So the recommendation would be to provide that baby aspirin to them at least in around 12 weeks all the way up to 28 weeks once when you're caring for them. If you notice that they didn't start it before, it shows some improvement in preventing preeclampsia from happening again. So if you can see here, a lot of folks end up falling into having two of the moderate risk factors, for instance, nulliparity and obesity. I live in the South. We have a very high BMI population down here, and so our first-time moms and obesity automatically puts them in a place where we would recommend aspirin. All right, so going back to our laboring patient, let's talk really quickly about fetal heart tracings. When you interpret them, that is our job. That's what we get paid for, right? We went to school. We understand what these tracings are. I'm not going to mention too much about how I feel about fetal heart tracings because it can be a pain. I don't know if anybody has looked into there was a great New York Times article about fetal heart tracings and the monitor being like the worst medical invention ever. That being said, we are stuck with it, and it's embraced our practice. But it's really interesting to see how I might read it, how Dr. Ganti might read it, how Dr. Liu might read a strip, or you might hand me that strip a week later, and I might read it a little bit differently, right? So it's what we have, and we have to deal with it. And so it's really important just to go through how you interpret your fetal heart tracing, thinking about the baseline, the variability, whether or not you're seeing accelerations and decelerations. And then last but not least, the other bottom line would be your uterine contractions. And just keeping in mind, like, what is this doing for us? How does it help? I do a lot of what I call strip rounds, because that's how I was trained at University of Illinois. We did a lot of tracings where we stared and talked about the labor course. And so you need to think about what the baseline is. You need to look at the variability. We'd like to keep it in the moderate range. And then accelerations or decelerations when one is laboring, it's part of the course, right? So the easiest way to think about labor categories is to know 1 and 3, and then 2 is always the one in the middle. And most patients that are laboring, the fetus will end up being in category 2. I mean, very rarely, but it's nice. Sometimes you get fetuses that just stay in category 1 the entire time. Even when the mom's pushing, there's like not even a deceleration when the baby's coming out. So if you just memorize 1 and 3, then you know everything else is 2. All right, so this is a strip with someone in labor. You can see the contractions that are happening, keeping in mind that the darker lines are a minute and then the boxes are 10 seconds in between. So this patient is, has a baseline of about 135, and then you can see that there's accelerations and the baby's doing well. So this is a category 1. And then this is now where the patient is in a second stage of labor, and you can see that they're starting to push. So when you notice that the contractions, you can't see the top of it anymore, or you start seeing there's like jagged edges, it's because they're actually pushing, and then that monitor on the external part of the abdomen is indicating some variability. And then these are decelerations. You should be able to definitely say that they're decelerations. Some people tell me, well, what about this little 10-second thing that goes a little bit below the baseline? If a deceleration really should last for at least 30 seconds. So these are clearly decelerations. You can't tell quite as well, but like when you do use a fetal scalp electrode, it should be better monitored and less variability. Okay, these are the stages of labor, and this should help you understand just like, where we are and help the patient as well understand labor. So dilated cervix, and then pushing. So when you talk about stage 1, it could take quite a while. And then as far as stage 2, you want to talk about how you can help them get through stage 2, and last but not least, the placental delivery. Okay, so when you talk about labor timing and expectations, when you really have to just keep in mind that usually spontaneous labor can be quicker, but at the same time, our laboring skills can make a labor go faster. It can also cause iatrogenic decels in the strip that can lead towards C-sections. So, everything we do in the laboring unit, it can lead to hopefully the best outcomes. And you can see certain teams do well, some teams not. And so that's where also like our QIs and looking at our providers' practice can help with increasing our vaginal delivery rates versus and decreasing our primary C-section rates. But this is all really important to just discuss with the team and our goals. I hope everybody, when you go on shift, our new interns, when they start, I'm always like, what are you doing on your shift today? And it's talking about how you're going to get someone delivered. Probably not going to deliver that one. And then talking about the different management. So as far as types of delivery, of course, there's vaginal, there's assisted, and then there's C-section. There's different indications for either using forceps or vacuum, and then, of course, going to the OR to deliver via C-section. Sometimes it's something you can find out right away in triage if it's someone who has a medical indication like HIV or active herpes lesions. And then the easy one is, of course, if they're breech, and then in labor. But vaginal delivery is your go-to. You really want to try to get theirs for every patient. You want to definitely allow the head to restitute when you see the head deliver. And restituting is just taking for you also to take a deep breath. I think a lot of times I see people kind of pull the shoulder into the pubic bone and they think they're having a shoulder, and I'm always like, okay, just take a deep breath. But that gentle downward pressure that we talk about, and then as soon as you see the anterior shoulder and pulling the body up, that decreases the pressure on the vaginal tissue, and then hopefully you won't have any tears. And that is the goal as an intern, is to end your intern year where you get less and less tears. Okay. Postpartum hemorrhage, there's a lot of good resources out there to help guide you as far as like what medications to use and when to go to the OR. I think the most important thing here is to remind yourself that you should be able to recognize it and recognize it quickly, because that's the part that will save a person's life. So always paying attention to your blood pressure, and always paying attention to the amount, and then asking the patient how they're doing. You'd be surprised that they're not feeling well. It's not that they're in pain, they're just not feeling well because they're losing too much blood and you're not paying attention. So every institution usually has like their own bundle and order sets to help guide you as far as when to call for massive um, transfusion and then what uterotonic drugs to use. Tranexamic acid is our friend and well used quite a lot now. It's helped to prevent further bleeding. You'd also want to call the team. So if you're worried about hemorrhage, you'd want anesthesia to know as well, so that if you had to go back to the OR for better visualization and control, because you might need to do some surgical intervention, then at least everybody's all together. There's a lot of other techniques using different balloons or um, compression devices or using sutures to compress the uterus. But that we don't have much time, so I'm going to just skip through that. So really, when you're laboring, just things to look out for. Always be prepared. Remind yourself when you go on shift that, what's it's almost like doing safety rounds. What is the concern that I might have for this particular patient who has a high BMI? Like, did I look at her abdomen? Do I know where I place the incision? If we had to go back to the OR for emergency section, always pay attention to the fetal heart tracing. You should never lose the fetal heart tones. If you see that the fetal heart tones are lost during contractions, guess what? You might have a baby coming out onto the bed because it's the heart is no longer being detected because the body is being pushed down with each contraction. Um, you there's bad outcomes on different labor and delivery units sometimes, and when you look back, it's because no one's paying attention to the strip and the baby's been off the monitor for quite a while. Um, I talked a little bit about the monitors not being great, but the first thing I say is that what do you look when you look at the strip, what do you say? And then the first thing is like if the baby's alive, right? Because I can see that there's a heart rate. And I can't emphasize that enough. That it's really important to make sure that you try to keep the baby on the monitor, even during epidural placements. Last but not least, things to look out for when you're helping out and maybe you're actually going to rupture the membranes. You want to avoid a cord prolapse. So techniques to avoid that would be like fundal pressure from an assistant to make sure the head's very engaged so that nothing can fall out when you're doing the rupture. And then as far as vaginal bleeding, you should always just keep that in the back of your mind. Like, is it truly just cervical changes, or is there a risk for abruption in this patient? And just knowing your patient's history. Last but not least, hypotension does occur with epidurals. It's just part of medicine. And we try to prevent that with giving them IV fluids prior to the epidural. But you need to just be available and around when the anesthesia team is helping out our patients with pain management. And that's it. Those are just kind of the pearls I have for laboring someone in obstetrics.
Awesome. Thank you so much, Dr. Gambala, and thank you to everyone, Dr. Ganti, Dr. Liu, for putting this together. Hopefully everybody here learned something today. We covered so many topics, and so that was really impressive to be able to do all of that in such a short period of time. I'll turn it over to Helen if you have anything to add before we close out.
Yeah, if everyone wants to just give another warm thank you to all of our speakers who did an incredible job today covering a lot of high yield topics. We really appreciate them. I think, unfortunately, we don't have time for questions at this point, but we really appreciate all the participation today and making this a very active session. If you all want to participate a little bit more, I dropped the feedback survey link as well, but it should pop up in the Zoom right after. We'd really appreciate your feedback on this session, and all of you who fill out the feedback survey will get the slides emailed as well. Thank you, everyone, and we hope to see you again at another boot camp. Have a great evening.